Thank you very much, gentlemen, ladies and gentlemen. As a vascular surgeon, our complications are not as severe as a cardiologist. And when I talk about complications, I talk about, for example, putting a patient on an antiplatelet aggregant without knowing if the patient's going to suffer side effects or not. My patients aren't going to die of a foot infarct. They're going to die of a cardiac infarct. However, understanding the genetics of a patient will tailor the individual care that you're going to have. And as a vascular surgeon, I think having all the right tools, having absolutely a clear understanding of my patient's biology and their response to a certain medication is very important. Last year for me, it was very exciting to adopt this modality into my practice. I'm a solo practitioner. I have about 12 employees who work under me, and being the head of that organization and trying to catch up to all the genetic testing and the follow-up is a challenge. But nevertheless, we work for the challenge to take care of our patients' best interest. So we're going to start with my slide presentation, and essentially I'm going to present a very typical case scenario. This is an 81-year-old female with history of peripheral arterial occlusive disease and a chronic non-healing ulceration of the right lower extremity. Patient was sent to me from a podiatry office with a huge list of medications. Has the typical past medical history: hypertension, diabetes, hyperlipidemia, previous smoker. We evaluated this patient in our ultrasound lab and found that she had high velocities through the superficial femoral artery in areas of occlusion, some dismal flow below the knee with an ABI that was, although 0.8 to 0.9, was not indicative of her true vascular disease. The patient was taken to the cath lab, had her first intervention on 9/4/2013. I found occlusion of the superficial femoral artery. That occlusion was opened up with atherectomy. A stent was placed. The outflow was through a single vessel, which was the perineal artery. I was content with my results, and I started the patient on Plavix, like 99.9% of vascular surgeons would after an intervention. She got her 300 milligram loading dose, followed by 75 milligrams of Plavix thereon. I followed her serially with ultrasounds to evaluate the success of my procedure and to identify any possible problems. At about the same time, I decided that I was going to implement the Genopath. I had not just completely convinced myself that Genopath was something for all my patients, but I gave it a try with this patient, and the report came back. This is a list of all her medications, so you can see that she's on multiple medications here, including my Plavix. And I got a report back, and this was before any issues started to happen on this patient, and I'm sure you're understanding where I'm going to lead to. She was deemed to be a CYP2C19 intermediate metabolizer on Plavix, which meant that the Plavix efficacy was not to its potential. And I disregarded it. I figured, well, 99% of the time my patients do fine. I don't have any issues. I didn't follow the recommendation. I continued doing the Genopath testing to all my other patients just to start getting a feel of it, to see the reports, and eventually, find a utility for it. So the patient comes back for her 3-month follow-up ultrasound examination. And lo and behold, to my disappointment, I find that my beautiful Supera stent that I put in that mid and distal SFA was gone. Her ABI was back down to 0.93. She was having symptoms in that leg. She was actually developing a small pressure ulceration in the distal part of her great toe. So I look back at her history. I look at the Genopath. And sporadically, us vascular surgeons will encounter a failure shortly after we've done a bypass or we've done a revascularization via an endovascular approach. And, we understand that the PPI combination with clopidogrel is an issue, et cetera, et cetera. So I started looking at all these. I looked at my genetic testing, and I realized, well, this is an intermediate metabolizer, so I got to change the medication regimen. So that's what I did. Based on the recommendations, I took the patient to the cath lab for a second try, but this time I went with a little more objectivity, having these results from the DNA testing lab and recommending the use of Effient or Brilinta instead of the Plavix, I decided to go with Effient. The guessing was removed out of the equation. I took this patient to the cath lab. These were my initial angiographic findings, which confirmed the occlusion of the SFA, as my lab determined. I decided to use rotational atherectomy since this was deemed a fresh thrombus. Cleared out my Supera stent. These were the results right after rotational atherectomy, which looked fine except for a proximal calcification there in the SFA. I decided to stent that. And my outflow, single vessel runoff as the original procedure. This time, with more information, obviously. My 1-month follow-up showed great results with ABIs increased, patient symptoms subsiding, and her ulceration healing. My 3-month follow-up, pretty much the same. 3 months into the first procedure, I had occlusion. 3 months into my second intervention, the graft's still open. She is still open, asymptomatic. I had to intervene in the other leg with the same issues, and so both of her legs have been readdressed, and they are now on the right medication. We all are concerned that there's not enough evidence out there to support genetic testing. But you guys have to remember, truly we're not all created equal. We all have a little bit of variations and respond differently to different stimuli and medications. Probably the largest, the giant trial, it was one of the ones that gave us an impetus in the utilization of this wonderful test. It showed that 22% of patients had a loss of a functional allele, deeming them slow responders to clopidogrel. However, what they did was they adjusted the medication, and they noticed that the patients who were normal responders and the adjusted slow responders had actually the same results. The study wasn't that large. However, I think it's significant enough to consider. This really has changed the way I practice. It has added an additional workload to my staff and myself, but I think it's helping the management of my patients in the long run. The other thing that I've noticed is the compliance of patients to medications. A lot of times we'll get a patient who has read the whole list of side effects, and they come to you and say, "Hey, doc, all these things can happen to me. What? Should I take this?" And they're doubting your recommendations. Now, they're not going to doubt your recommendations because you're coming in with an objective analysis that's going to say, "Hey, this is what you're made of, and these are the medications that you can take safely." So that's given me the confidence in my practice to utilize this as an additional tool to provide that elevated echelon in the art of practicing medicine. In conclusion, understanding an individual's genetic predisposition truly enables us to tailor their medication regimen and obtain successful results, avoiding the non-desired effects. It is also clear that by eliminating the uncertainty from the minds of our patients, we will gain the adherence, the compliance of the recommended drug regimens. Remembering what Sir William Osler said, if it were not for the great variability among individuals, medicine might as well be a science, not an art. Boils down to, my friends, that it's all about genetics.